From Redox and Healthcare Strategy Bullpen, welcome to Diagnosing Healthtech.
Good afternoon, or good morning, depending on where you are and when you're listening. My name is Jeff Englander. I'm the founder and principal of the Healthcare Strategy Bullpen, and I am delighted to welcome you to today's episode of Diagnosing Healthtech. And with me today for her very last episode for a while, I am also delighted to welcome Carolyn Brinkerhoff. Carolyn, welcome.
Hello, thank you. Yes, I am headed out on parental leave soon. Got two babies coming along the way. Got twins coming. So I'm excited to do this last interview, and then I will focus on my family for a while once we get that started.
As the father of twins, I will just say, master the zone defense. That's my only suggestion for right now. But congratulations, and wish you all the best. And have some comments at the end. But thank you for joining us today, Carolyn. And I'd like to welcome our guest, Don Rucker. He's the Chief Strategy Officer of One Up Health. Prior to his role at One Up Health, Don was the national coordinator at ONC, where he led the writing of the 21st Century Cures Act and the interoperability rule. Don also pioneered policy building on HL7 block FHIR, and he co-developed the first Windows-based EMR. Don has been a practicing emergency medicine physician for over 30 years. He's on the adjunct faculty at Ohio State University Department of Emergency Medicine. He's also a graduate of Harvard and the University of Pennsylvania School of Medicine, and he's board certified in emergency medicine, internal medicine, and clinical informatics. And he has an MBA and an MS in medical computer science, both from Stanford. So Don, welcome.
Thank you.
So Don, when we were talking about the call, and the idea behind today's podcast is being smarter about how we use data in healthcare, you mentioned kind of the analogy of providers having 1 foot kind of in the boat and 1 foot on shore, or there's a bunch of different ways to look at the analogy. Can you talk about that analogy, kind of define it and explain what you mean?
Sure. This is a somewhat common analogy on the provider side, which is that providers are in this funny world, many providers, maybe most providers, where on the one hand, they're in a fee-for-service environment, AKA you earn more by doing more. And on the other hand, they're in some type of a capitated environment where you earn more by arguably doing less. And obviously that's innately schizophrenic because it's essentially impossible and arguably immoral to keep those utterly divergent strategies in mind when you're taking care of individual patients, right? If you have somebody sitting in your exam room or ER or hospital bed, it's very hard, if you can even, they're under this, I should do more or I should do less. I think that's one big thing. I think the other big thing we talked about is that maybe for that reason, maybe for others, but I think in a subtle way, not even a spoken way, the policy world is moving to having care allocated increasingly by payers. I think if you look over the last 20 years, let's say over the last 40 or 50 years, right? So let's go back to the start of Medicare in 65. It wasn't much of a thing in the early days for a variety of reasons. And then as Medicare and government payments started kicking in, I would say in the 80s and 90s, it was pretty much the government would pay on demand, sort of the famous any willing provider. So if you had a license and you weren't committing, obvious malpractice or criminal behavior, you'd get paid. Sort of circa 2000, the notions of value-based care started coming in. And I would argue over the last 20 years, we've been in this environment of value-based care. And, it's always been a funny environment because most of the conversation has, right, value in our personal lives, unlike value in healthcare. Value in our personal lives is what do you get and what do you pay for it?
Mm-hmm.
I mean, you go to the store, it's like the basic consumer choice in everything. In healthcare, we've done this sort of odd thing where we've sort of fixed the prices, arguably, certainly the government prices. And so all we sort of measure is the quality. And so we've had quality measurements for roughly 20 odd years. And I think net, for a variety of reasons, maybe we'll get into them, maybe not, that's turned out to be not really adequate to the task of allocating care. The expenses are still growing. The issues with the innate value are still there. So increasingly what you're seeing is de facto that more and more of the choices in care, the actual delivery choices, are being farmed out to payers. And probably, you see that in a lot of the plans, commercial plans under ERISA, high deductible contracts. But of course, the biggest place where you see that hands down is in Medicare Advantage and then managed Medicaid, right? Those are just massive programs where essentially the payers are delegated with the responsibility of what care to administer. And, Jeff, when we talked, it was really the data questions of how do payers do that? How do payers allocate care in a modern way that I think are very interesting, hopefully of fascinating interest for your audience.
Yeah, let me follow up on that a little bit. And one of the things we talked about was the fact that, prior to value-based care, and we'll talk more about this, is payers have really never had to deal with, clinical data at scale.
Right. Yeah.
And managing and using data. And can you talk more about how that's coming more into the picture? And we're moving towards, for our listeners, the idea that payers and providers are going to have to share more data and have to make the data more available. So it's not just interoperability, it's data sharing and willingness to data share. So can you talk about that a little bit more?
Oh yeah, I could even probably talk about it a lot more.
So we got a bunch of a show to kill here. So
yeah. So I would say when you look at, and this is something that frankly bedeviled us at ONC and at HITech and National Center for Vital Healthcare Statistics and the CMS data office, for a lot of the policy considerations. Historically, we've had almost two totally disconnected data streams in healthcare. We've had the provider side EHR data stream, right? And, the system of record has been EHRs. And that has, unlike almost any other industry where the enterprise software is geared towards automation, in healthcare, the enterprise software of record, the EHR, has first and foremost been geared towards more documentation to get paid more. Just, bizarre, but that's not on the EHR vendors, that's on the policy community. We created globally, Congress created the incentives and people respond. Nothing new there. That's human nature. So means, of course, we have to rethink those policies in a fundamental way. But that's been one stream. Almost unconnected has been the sort of, let's call it the revenue cycle stream of data. And so, for the audience, for those of you who may not know, when a patient is seen, their codes are generated, often at great cost. I mean, it might be 5 or 6% of the whole enterprise. And the EHR is codified, and a series of billing codes are sent, and they start on the provider side in what's called revenue cycle, which is pretty much exactly what you think might be, which is getting paid. And unlike your credit card or a bank ACH thing, where those things might be near instantaneous, here, this goes through a labor of love. Maybe that's a total misnomer of this cycle.
I think that's the first time I've ever heard revenue cycle referred to as a labor of love.
But yes, the love of money, mostly, I would say, to be honest. But so the revenue cycle, so you get these codes. These codes are then submitted classically to a claims clearinghouse. There are other ways of doing it, but classically to a claims clearinghouse. Claims clearinghouse then has its own ecosystem of people who allocate care, partition care, do all kinds of things that if you're not in that space, you'd never even imagine are being done. And then after some fiddling, they are sent to the payers to get paid or not paid. And then the payers ingest this data in something, relatively accurately described as a claims engine. And they then decide, and then the whole circle almost like reverses itself. So, it's like the tides. The claims come in, and then, the payments hopefully sort of shift out. It's not exactly the Bay of Fundy. Takes, 50 days. So it's not on a lunar calendar. Maybe it's on a lunar calendar. It's certainly not on a solar cycle. And these things go back. Some are paid, some are not. Some are require more data. Some go through other side channels like prior authorization. That whole world is where the finance is and the dollar flows. And it really has not been connected. What you will notice in that is there is only the scarcest connection to the clinical enterprise. The glue that ties the financial data to the clinical data is like a microscopic hair of ICD-10 diagnosis codes and CPT-4 billing codes from which you might infer data, right? So if there's a code for, let's say, transurethral prostatectomy, well, they had a transurethral prostatectomy. If, many of these are for what are called evaluation and management, which are office visit codes, by specialty. But the dominant feature in this whole cycle, and there are variations at CMS, for Medicare fee-for-service, it goes to these Medicare administrative contractors, but sort of the same concept. The dominant feature there is there's an almost total disconnect between clinical data and payment data in those two pipelines. And so how on earth are we truly going to pay for value if the data streams are disconnected?
Yeah. Carolyn, did you have a question?
Oh man, I have so many questions, Don. I think from my perspective, I think that yes, there's this tiny piece of a diagnosis code, a billing code that connects a patient from the rev cycle. And from your perspective, like what are the biggest gaps to close in connecting the two and reconciling the two between the clinical care and the revenue cycle billing processes?
Yeah, Carolyn. So I think what ultimately is needed, right, is if payers are going to allocate care, and it may just be worth a second to remember, how do payers allocate care, right? Some of it is by what they pay, right, what they incent. Other large parts of it are what they authorize, so prior authorization, which is a huge political football. We know that many payers are running a vast amount of services through prior authorization, almost an entire dead loss to the economy, delay in patient care, maddening for providers. I, for my personal medical issues, spend roughly 100 hours a year personally on phone calls trying to get the care I need. And it's not even like there's a clinical issue. I'm not going to get into my medical issues, but it's like pretty cut and dry. I don't think anybody with a straight face would say these things aren't indicated. But the system sort of allows this friction, I guess, on the thought that some people will just not persevere or die or whatever, or just be denied. And it's maddening to the country, and Congress is quite aware of it, right? This is the kind of stuff that gets to, I was just talking with a colleague who's being sued for, care in administered by a nursing home where she co-signed an admission in quirky ways. All this stuff is a huge dissatisfier to the country. But there are more subtle things like network design, right? If you don't have a provider network, you're not going to be delivering that care. CMS is now obviously interested in this. They realize this. And then I think there's sort of the macro consideration, Carolyn, it's that a lot of really smart folks who are in a position to really know believe we're potentially overpaying Medicare Advantage on a dollars to dollars basis by 20%, right? So, Don Berwick has said that. David Blumenthal has had a version of that in the New England Journal back in December. Richard Gilfillan, if I'm pronouncing his name correctly, who was the head of CMMI and then Trinity. So, the question, of course, is what to do about it. And that delta between Medicare fee-for-service and MA is sort of growing because sicker patients want to have their care covered. So they're staying in fee-for-service, and poorer patients are going into Medicare Advantage. So those things which were designed with great effort to be sort of equivalent are increasingly not. And ultimately, data is going to be the glue that sort of realigns all of these things. And so, that brings us to, the next questions, which I will leave to you.
So did you have a follow-up, Carolyn, or should I go?
Go ahead, Jeff. It sounds like you're itching to ask something.
Oh, I'm always itching to ask something. Ask my kids. You mentioned that, payers are now allocating care, but providers have all the clinical data that you're talking about, but they're really, they're not configured, particularly with, EMRs, which only have, I think, 20 to 30% of the data to use it. So, in that situation, the data is very siloed. Care is spread out amongst a number of different sites of care. They all don't share common EMRs. So if the payers are allocating care and the providers aren't configured to use the claims data they have, how do you make data more accessible, and how do you make data sharing and using data smarter?
Yeah. There are ways to do it just within EHRs, arguably, just on the provider side. But let's talk about that sort of joint work product of providers and payers, because I think this is the world where we're in now. And, what is needed is a better picture on the payer side of who the patient is. What are the patient's issues? Now, obviously, the payers, have a stream of claims data, which in many cases, especially if a patient is sort of hopping between providers and different EHRs, obviously many of the provider oligopolies are doing their level best to prevent patients from shopping for care. Right? I mean, that consolidation could be probably multiple other podcasts, some of which I'm guessing you've already had. Right. But, obviously modulo that the providers are trying to prevent patients from, as they put it, leaking out of the system. payers right now infer literally from these limited CPT and ICD-10 codes. So any additional data they have would give them a richer picture, right? They don't necessarily even need the complete data that a practicing doc would have, right? And even that's hard, right? If you're seeing patients, it's actually hard to get all the data, right? You don't have enough time to read it. The patient may not remember. You can't get it from them in the history. Time is short. Patients have their, why the reason they're seeing you. And at the moment, we don't really have, great AI capabilities to sort of backfill in the surround. We will. That stuff is moving along at warp speed. But at the moment, we don't have that. And so I believe payers would actually be quite informed with even a bit more data, right? And the data that they would likely be informed with is what's called the US Core Data for Interoperability, which is an ONC construct going back, I don't know, almost 10 years. I think in formal rulemaking was when I was at ONC, but that work, predated, all the initial work predated, my arrival in the Cures Act rulemaking. That was just sort of the vehicle for that. And that data includes some notes, includes med lists, includes allergies, includes problem lists, lab results. Not necessarily a complete thing, but a very high information density, right? You can almost think of it, a change of shift as a sign out. So let's say it's change of shift in the ER. I'm signing out to my colleague. You try to take care of the patient, discharge him, but if you don't, if you sign the patient out or inpatient, you try to give a quick history of this. That's what this data is, but that actually gives you a great picture for action, right? You sort of know what are the chronic illnesses. It would give you far more information when you're deciding on something like prior authorization. Now, the latest CMS rules are trying to force that in. So the CMS API rules that they just released, I believe in January? Yeah, a couple months ago. So CMS 0057 F, that rule, is now expanding the required APIs to provide the street, pave the roads on these data sharing things. So the payers have to share data with providers. They have to share data with, on upcoming payer. If patients are switching, they already have to share with patients. So, and that includes prior auth decision making, which is real powerful, in the time type of thing. And it's the structured data, the US CDI, payers have to share some unstructured data as well. So that's what we're seeing as the big first step here. And so everybody is scrambling to build these APIs, which are nominally due January 1st, 2027. But, you really need to get started earlier because there's a whole bunch of prep work, including the fact that you have to report on your prior auth performance January or the beginning of 2026 for what you did in 2025. So you already, as a payer, are required to, payer that's regulated by CMS, required to keep track of all of this beginning, January 1st of next year. So, the roads are being paved here. And, there'll be many, many more folks using this data as time goes on. But, the early part is in place as we speak.
So we have the framework, we have structure, we have a list of data elements that we know are going to help support connecting payers and providers together in a way to help improve care, create more of a value-based care, in the US. We're still years away from it actually being required. So what strategies can be implemented along the way? Like how can we incentivize providers and payers to work together in the meantime?
Well, years away is pretty quick, right? So some of this stuff is January of next year. So that's less than a year.
Yes.
And the APIs have to be up and running, and some of them, the payer patient API, are already required, right? So you already are required to have your data in FHIR, all of the relevant data, that like in importantly, claims data, other clinical data you may have. So that's required as we speak. I think the big forcing function, frankly, is going to be Medicare Advantage and then Medicaid managed Medicaid reporting requirements to CMS, right? CMS, Congress isn't going to pass a new Medicare Advantage law, I don't believe. The political will is not there in the current political landscape. There's an election coming up, so who knows? 2025. But at the moment, this calendar year. But I assure you, CMS, and they got great people working at CMS. It's really quite a competent organization. That's been my experience. I've been uniformly impressed with the folks, at CMS. They are looking to get more data, and whether that is in the risk scoring, the hierarchical condition classification, whether that is in adequacy of network design, whether that is in scrutiny of prior authorization, whether that is in SDOH type of measures. They're pushing to get more data, and they can do those requirements easily on an annual basis, right? They write 10,000 pages of payment rules a year, as it turns out, at CMS, right? So when you think about, the various Medicare, inpatient, outpatient, HOPS, the hospital prospective system, long-term care, home care, there's a lot of, the repricing of every service. There's a lot of annual rewriting of this. So I think you're going to see more and more there. And there's nothing that says they can't release rules as they come up with them. Maybe the most interesting from a weird stats point of view is this thing called Tukey Gate. I don't know if your audience has followed that. John Tukey was a very famous statistician back in the days of, pre-heavy computerization of statistics. Now, of course, it's all machine learning and AI, but back in the day, and he had all of these outlier algorithms. CMS is using the Tukey outlier algorithms to pay less to MA plans. Elevance has taken them to court on this. All of these, the churn in MA plans right now, CVS and Humana both said, I think a week ago or 2 weeks ago, that they were going to anticipate losing members.
Yeah.
Because of, it was a little hazy about whether these were unprofitable members or the members, they didn't have a competitive product to offer certain tranches of members. But MA has become a more competitive space, right? And you've seen this, from United, from Elevance, from Humana, Centene, CVS. All of these folks are, having to rejigger their products, and those rejiggerings are ultimately exercises in computer science and data, right? I mean, they cannot not be. I always hate to have a double negative, but hopefully it serves the point here.
So Don, one of the things we talked about is the way care is going to be allocated in the future is going to change even from value-based care. What are the things that we need to think about now about connecting data to the way care is going to be allocated in the future?
It probably takes near zero imagination, but of course, even that's hard to muster in American healthcare. Now, hey, that's maybe just an unfair comment, but I'm talking more about the delivery and payment side, not the biologic innovation and the incredible marvels of gene sequencing and modern imaging and diagnostics. I'm talking about the bricks and mortar type of allocation of care and payment policy. But the consumerization of our lives, we all know it. It's been almost totally missing in healthcare, right? Prevention has been essentially totally missing in healthcare, right?
Yeah.
We have these sort of very narrow views of prevention, which are, obviously, don't smoke, don't drink, get off your butt. But those are really pretty coarse tools when today, with what are ultimately extremely inexpensive technologies. I mean, the cardiac CT angiogram to see whether you have plaque 10 years before your heart attack, and that's the warranty period, could easily be done in a market economy for well under $100. Would you want to? And then you can take lots of statins and prevent having a heart attack or a stroke. Would most people, if offered the choice to spend $100 10-year advance, so one less steak dinner at a fancy restaurant, what is that? 10, is that even? I don't know. I don't smoke, but what is that? 10 packs of cigarettes?
Might even be with the way the costs are gone up on the cigarettes.
Yeah. Right? Would you rather spend that and know whether you're going to have a heart attack in 10 years and then go to Walmart for $4 a month and buy Lipitor, generic Lipitor? We could do vastly more highly tailored prevention than we're doing now. And it can be entirely personalized. Everybody has a phone. Every one of those phones these days has an accelerometer and a GPS. You can predict somebody's health and fitness to a T from just those two data acquisition things, which every one of us has.
You mean from like a gait analysis, Don, or
gait, sitting, inertia, right? I mean, how much of the time are we spending sitting in front of our computer with the phone, on our desk or the mobile? How much are we walking, right, on the GPS, right? And you can de-identify, but, is your GPS at the gym? Are you out, training for the Tour de France? Are you at the liquor store? Right. I mean, you don't have to be a great data science person to do all of this. And then you can tailor highly likely to be effective intervention strategies. And they don't even necessarily require, monster lifestyle changes, right? They may just be blood pressure control first and foremost, or they may just be statin control or both, right? Maybe a little bit touching on weight control, right? These things are available with the data we have today. So, Jeff, to answer your question, are we going to ignore all of this data? Are we just going to ignore it? Or are we going to come up with payment plans and put people into economic incentives to take care of themselves, right? From this very passive world that we've created with since 1942 in the Stabilization Act, making healthcare pre-tax, right? Which we ultimately have to get rid of. As long as healthcare is pre-tax and employers are paying for this, there won't really be the tools for us to take care of our bodies because we remain disempowered from that. As long as the man, if you will, is taking care of us, we should. I mean, that would be the single greatest improvement in healthcare would be to wean us off of that and come up with a plan. I think President Obama tried in the teeniest little way with the Cadillac tax. He dipped his toe in the water and I guess it was too cold and he immediately withdrew his toe. I didn't even think he got the whole toe in, let alone the foot, or went swimming. But maybe someday we'll have a political leader from some party who will wean us off of that and handle the equity and morality issues on the side. And we know how to do that. We do that in food stamps, right? food stamps have totally uncoupled the provision of care from the equity issues, right? We're not, Medicare, CMS is not running grocery stores, right? We don't have a center for the administration of food banks.
Yeah.
Right? We go to the grocery store, we can buy whatever shit we want. Some of it good, some of it maybe not. But it's uncoupled. And that's what we need in healthcare. And then, we can make choices, and there will be, incentives as we learn more, right? If you have a picture of your coronary arteries and you see that plaque that's about to kill you, that might be a moderately strong incentive to do something. Has been for many, many people. So we have all kinds of options. Ultimately, they come down to real-time data to consumers, and eventually plan design will have to do in healthcare what auto insurance often does if you get one of those OBE or whatever it's called, the onboard monitor devices you can plug into your car and get a good driver discount for, not being a crazy driver. We need that in healthcare, and eventually it'll happen, because otherwise the entire GDP will be swallowed by healthcare. And if China takes over, I can assure you that all is going to come to an end.
I think there's a whole host of tax discussions that we can have there. Maybe one day we'll have John Gruber back, and you and he can talk about uncoupling the incentives on employer-sponsored health insurance. But Carolyn,
yeah. Well, I think he had the right idea. He may have been monumentally ineffective in messaging.
Well, yeah, we may have to talk about that too. But Carolyn, did you have a follow-up?
Yeah, I am curious from your perspective, with all these really incredible advances in technology and modern computing and ways that we can assess health, which parties in healthcare are experimenting with this the most, or pushing for making these changes the most? Like, you've been on so many different sides of it as a physician working for the ONC. Who wants to be the early adopter? Like, who is really pushing for these changes?
So the folks who are doing a lot of this, who are in the current payment pipeline, are obviously the diagnostic companies. I was chief medical officer for Siemens. I mean, you look at modern MRIs or CT scans, they are stunning, right? They are stunning. And of course, we all know about, gene sequencing and the, monumental price drops there, and the potential, and, personalized pharmacogenomics. Those are all people who are more or less in the current payment pipeline, maybe not for prevention, but for diagnosis. Obviously, there are people more on the data and use of the data that are, in part using current business model and, regulatory regimes. In part will, need to pioneer new business models, the generative AI type of work, right? I mean, we talked about using cardiac CT angiogram to diagnose the future. By way of disclaimer, in addition to One Up Health, I'm an advisor to a company called GenHealth.ai, founded by Ricky Sahu, who also founded One Up Health. And they have come up with incredible powers of prediction on just future spending on healthcare, right? These data models, especially if you have a underlying smart data representation that, allows regularization, vectorization, all the things you need in order to have this universe work, which in many cases just getting the data into a FHIR platform in the cloud. They're poised to harvest that. Now, what the payment models are here, I think, are, to be determined. And obviously, folks will try to shoehorn into a current payment model, right? Whether that is, prior auth, or some type of risk scoring, or euphemistic Medicare Advantage optimization, right? So people are obviously going to try to shoe in. At the moment, getting new billing codes is essentially impossible. The assignment of codes through the AMA. Now, sometimes CMS just bites takes the bull by the horn and issues new codes. But if you're going through the AMA, that's sort of a exercise in restraint of trade.
Did you have another follow-up, Carolyn? I know this is going to be your last one for a while. Are you sure you don't have one more?
That is all right with me, Jeff. You can close it out.
So one last question, Don. What are one or two things that you think practically and realistically we could do to get payers and providers working better together, just as a general rule?
I think payers and providers need to realize that they actually have shared interests here. Historically, it's all been about counterparty negotiation, but in this new world, they're going to have to start thinking about sharing. We already have the APIs to do it with FHIR. We have the data streams. It should be, payers should, I think, put requirements to get the bulk FHIR API reporting from providers, which again is a mandated API. It's a batch mode, but write that into every one of their network contracts. And providers should start thinking about how they can show their value here using these analytic tools, right? I mean, they have access to the same data, and we have the regulatory framework in place, and they should start doing this. The tools are there, the APIs are there, and I think increasingly they have incentives to do this. There's a lot of friction in prior authorization. Solving some of that pays for some of these other things.
Yeah.
And obviously, CMS is doing a great job reducing friction. O&C may be increasing friction with TEFCA. That's a whole other topic that's sort of going backwards in time to a totally insecure architecture. But certainly CMS is using modern APIs and modern data stores.
Yeah, well, I think that's very helpful. Well, Don, thank you so much. We really appreciate it. We will maybe keep you queued up for that other tax and policy discussion, maybe you'll come lecture to my healthcare economics class. But I want to thank you very much for joining us. We really appreciate it. Very helpful advice. And I think this is a topic that we'll definitely have to come back to.
Thanks. Yeah. Interesting times. A lot to think about.
Yes. So with that, we will move to our discussion articles. And two discussion articles today. Very interesting article from the Compass newsletter from Trillion Health. This first was about the market shift in urgent care utilization 2 years later. This was an update to a report they did in 2022. And what they're saying was the number of urgent care centers in the U.S. has almost doubled between 2014 and the middle of 2023. However, while urgent care utilization has increased by 19% from the second quarter of 2019 to the second quarter of 2023, the number of U.S. urgent care centers, this is excluding COVID, the number of urgent care centers rose over 25% during the same period. So what this is suggesting is that the growth in urgent care centers is outpacing the growth in usage, and there's a bit of an oversupply. And what they also mentioned was excluding COVID volumes, it wasn't until the second quarter of 2023 that urgent care volumes got back to the pre-COVID levels. Interestingly enough, they also found that new entrants such as Walmart currently deliver less than 1% of low acuity care. And going back to their 2022 study, they repeated that preventive primary care demand continues to track below pre-pandemic levels, which is something they found in the 2022 study. And it underscored the need for what they called multi-stakeholder intervention to address these gaps, particularly in low income and rural areas. I would agree with the study on a lot of fronts. The thought was during the big pickup in utilization in urgent care clinics during COVID that people would start to use them more for some more non-urgent care, or you would see an increase in the acuity of care that was coming in during COVID. That hasn't happened as much. And the other thing is you've seen a big deferral of care during COVID, and that's still, particularly in oncology screening, diabetes screening, on the other things, that still has been a problem. I've talked to a number of employers who've had some very high cost claims, where they have hit their stopgap insurance because of people who waited to get care. And when we did go in to get care, they found some very serious situations. So I think there's still pent-up demand from COVID. You've seen that, I think, in part of what's driving the increased usage and utilization, or same thing, increased utilization in Medicare Advantage. And I think that is one of the problems that we're continuing to deal with here today. And it's probably going to continue, I would say, at least through the end of 24. Any particular comments you wanted to add, Carolyn?
Yeah, I mean, I think I agree with this article overall. Like, I don't think urgent cares are going to disappear altogether in any way. It is interesting to see how so many different parts of the healthcare industry expanded so quickly during COVID-19, especially those areas that supported telehealth in some way, or being able to support rapid testing with COVID, or just any kind of treatment or care related to COVID. And now that we've seen that past, everything is kind of correcting itself, and we're seeing those seeing the numbers change and be a little bit different. The growth looks a little bit different here. But at the same time, like, urgent cares are still highly needed to, keep the right people going to the emergency department, and also like to get people in to see a physician when they can't get into their PCP, or they can't get into the, healthcare they need at that moment. And I think we will see continued telehealth triage with urgent care and things like that. So I don't think the virtual visits are necessarily disappearing either. But Jeff, you and I were chatting about this article a little bit earlier, thinking about those big box retailers going into urgent care, and seeing some of those reports come out in the past. Tell me a little bit what you think about around like Walmart, Walgreens, CVS going into the space, and how they are reacting to these numbers.
Yeah, no, I think the report's absolutely right. I think you're still seeing low volumes of low acuity care going into these platforms. I think that's one of the reasons you see people like Walmart, people like Walgreens, to a certain extent, CVS, even Optum with virtual care. It's very difficult to make money on primary care. No one has really ever made money on primary care. The thing is, my understanding is, given the workforce shortage, in particular Walmart and some others, they had to pay up to hire some of these doctors, and it made it very difficult for them to make the economics work. And if the unit economics don't work, as Walgreens found out, then that creates the problem. So I do think this will continue to be a problem for a while. With that, let me move to the second article. The second article is a report called The Generative AI Roadmap, Its Hurdles and Strategies to Mitigate. And it's a fierce article story on an Institute for Healthcare Improvement report. And the report identified a number of risks to AI, including the depersonalization of care, inaccuracies and bias, challenges with integration, and what it called workforce deskilling. So to start off, the report identified 6 best practices to guide the ongoing development of generative AI tools and integration into care delivery. So first was to serve and safeguard the patient. Second was to learn with, engage, and listen to clinicians, which I think is extremely important always, particularly the frontline clinicians. Evaluate and ensure AI efficacy and freedom from bias, which we all know. Establish strict AI governance, oversight, and guidance for health systems with the federal government. Be intentional with the design, implementation, and ongoing evaluation of AI tools. and engage and collaborate learning across the system. So the report built its recommendations around 3 areas anticipated as primary use cases to be primary use cases for generative AI in the near future. First was documentation support, which was developing patient history summaries, transcribing conversations, drafting responses to patient messages. The report cited the risk or the lack of patient transparency or informed consent on the uses of these types of tools with patients. Clinicians may have to spend more time manually reviewing some of the flagged inaccuracies, not just thoughtful procurement, but ongoing auditing, which I think is, a lot of thought is being put into buying these tools, but a significant amount of time is going to have to be put into making sure we're auditing the use of these tools. And the report also talked about de-skilling, which was identified as a threat as clinicians begin to over-rely on the tool, leading doctors to make unnoticed errors or poor oversight of the AI systems. The report also talked about clinical decision support systems. These can help doctors with early detection of changes in patient conditions or suggest treatment plans. One of the issues here was they felt that the doctors have to be cautious and hospitals have to be cautious because this can contribute to alert fatigue on the part of physicians. And you need digital ways to audit these algorithms, once again, coming back to oversight of these systems when they're in place, since clinicians can't double check every recommendation. And also they talked about patient chatbots, which you're all familiar with. The report suggested that we embed disclosures of a chat box function for patients. We design chatbots with guide rails, and we ensure escalation pathways for chatbot users, also having certain prompts chatbots can't respond to. So overall, I think it's a good report. I think it's a strong report. I don't think there's any surprise in what the report talked about in terms of transparency, bias, and working with clinicians. I think two really strong recommendations rather it made were, one is that we pay as much attention to these things, not only in the acquisition, but in the ongoing management and running of these, and that a lot of attention has to be paid to what information we give patients and what kind of informed consent we get from them, and making sure that as these models change, this is adaptive AI, and as these models change, we make sure that patients are informed with their consent about how these models are changing. Any comments on your end, Carolyn?
All of these concerns are things that I have seen in the news, things that I've heard from physicians around adopting AI. So I think that they definitely covered all of the potential possibilities or pushback, like reliance upon de-skilling, alert fatigue, all of these things that could hinder provision of care or hinder the care given to patients. And I think it also does a pretty good job covering how the potential that generative AI has in improving things like diagnostic accuracy and different areas in healthcare in which this could be really beneficial for us to solve problems, and ultimately watching it and training it, and appropriate disclosures about it are all very important in order for this to be adopted in healthcare overall. So I think overall, a lot of this is a very clear summary of things that I have seen in the news ever since AI started getting big, right? So I think that they were able to cover a lot of around the different use cases and potential concerns.
Yeah, no, I think one of the points they made is just kind of on the de-skilling was they gave the analogy of TSA agents who were, trained and retrained about spotting guns and things in luggage, because they tend to over-rely on the technology. And I think that's similar to, with doctors. And so I think those are all, good points made in the report. So with that, let me go ahead and wrap it up. As I said, I'm Jeff England. I'm the founder and principal of the Healthcare Strategy Bullpen. We help providers adapt and deploy healthcare tech to improve the lives of their patients. We help health tech innovators be more effective in deploying and developing their technology within the healthcare delivery ecosystem. We focus on 4 areas, really: operationalizing data to help improve its analytical value, demonstrating the benefits of new applications enabled by digital technology, helping apply digital technology to the management of high cost and chronic conditions, and gauging and managing the practical, cultural, and technological issues around implementing the social determinants of health. Please check out our latest blog, which is on ensuring that digital health reduces, not aggravates, the inequities in healthcare, which is on our website. Please do follow us on LinkedIn, Twitter, or X, and at healthcarebullpen.com on LinkedIn and at healthcarepen on X. Please do subscribe to our blog and subscribe to Diagnosing Healthtech on your favorite platform. And before I do turn it back over to Carolyn, I would just like to say a special thank you on my part. Carolyn joined us as one of our first co-hosts. She got into this, as you can imagine, as a new venture for all of us, not knowing what we were stepping into, not knowing how it was going to work. For those of you who don't know, the co-hosts from Redox do this in addition to their day jobs. And Carolyn was wonderful. Carolyn several times got thrown into situations with very little or no preparation whatsoever and stepped in just without hesitation. So from my perspective, and I just wanted to offer my personal thank you for all of her time, all of her graciousness, and just being willing to come in and do what was necessary to help make the show a success. So Carolyn, I wish you all the best with the twins, and offer whatever limited advice I have. And thank you so much for helping us get the show off the ground.
That's so sweet. Thank you, Jeff. I appreciate it. Well, I will be seeing you guys in a handful of months. But to wrap everything up, our show is also sponsored by Redox, the healthcare integration platform that specializes in the implementation of big data, AI, and cloud computing. You can be sure to subscribe to Diagnosing Healthtech on any podcast platform, or scan this QR code that's up on the screen to get updates. From all of us at Diagnosing Healthtech, thanks for watching. I won't see you next time. Jeff will, but we'll see you soon.
Take care.